Hello, and thank you for joining us. My name is Sarah Yacoub, and I'd like to welcome you to today's CDC Partner Update call on COVID-19. This call serves as a way for CDC to share weekly updates on the COVID-19 situation and our latest resources and guidance, especially for the private sector and other partners. Our topic of focus today is the considerations for businesses, manufacturing, and the general public. Our plan is to hear an update from our Chief Medical Officer about what everyone should know about protecting themselves and others. We'll then hear from two of our experts about CDC's new Resuming Business Toolkit and interim guidance for manufacturing workers and employers. Afterwards, our speakers will take questions from the audience. This call is not intended for media. Media can direct their questions to media@cdc.gov. This call will be recorded and later posted on the CDC COVID-19 website as well as YouTube. As you may have noticed, our call today is at 3 p.m. as opposed to our normal time slot of 4 p.m. We may be changing the time to 3 p.m. in the future. We'll definitely keep you posted on that, or we may zoom right back to 4 p.m. So again, we'll definitely keep everyone informed as we make those decisions over the next week. But before we begin, I'd like to remind all participants that the CDC website has the latest information, guidance, and communication resources. There are over 1,500 documents providing information and guidance for individuals, businesses, and the public on our website. In addition to the tools we'll highlight today, just a few examples of what's been posted in the last few weeks includes workforce decision tools, COVID-19 employer information for office buildings, interim guidelines for the COVID-19 antibody testing, and COVID-19 in racial and ethnic minority groups. Thank you to those who sent questions in advance. We've teed up some of those questions for our speakers, and I'll also be keeping an eye on the Q&A box, so please feel welcome to submit questions there as well. For those of you logged into the webinar platform, please just be aware that there aren't many slides associated with today's conversation, so you shouldn't expect for those slides to advance. However, a transcript will be provided along with this video when it's posted on YouTube. Excuse me. I am pleased to be joined today by three CDC speakers. Dr. John Brooks is the Chief Medical Officer for the CDC COVID-19 response and previously has led teams at CDC responsible for Ebola, Zika, anthrax, and other emergencies. Captain Dwayne Hammond is a subject matter expert on CDC's COVID-19 worker safety team and a captain in the U.S. Public Health Services Commission Course. And Dr. Ray J. Matatic is the Associate Director for Manufacturing in CDC's National Institute for Occupational Health and Safety, Occupational Safety and Health, also known as, for some of you, NIOSH. I'd like to now turn it over to Dr. Brooks for some updates.
Thank you, Sarah, for that very generous introduction, and thank you also to the many people who are on the line with us today. I think we're approaching 500, so that's terrific. So, as Sarah mentioned, I'm John Brooks, and I'm very pleased to participate today in my role as the Chief Medical Officer for this response. Just so you know what we do in my office, my team's really responsible for reviewing and evaluating all of the latest scientific evidence on COVID-19 and figuring out how to best apply that for protecting patients and communities in this ongoing pandemic, as well as to inform our efforts in the response. So I'm pretty up to speed with most of the literature, and if you know of something I'm not aware of or you bring it to my attention, I'd be very grateful. Thank you. I'll also mention that I still practice as an infectious disease doctor. I've been in the business now about 35 years. Spent most of my time in that period talking to patients and treating them. Like many infectious disease doctors, HIV has comprised a very large part of my medical practice. But today, I want to talk to you all and provide a brief update on the COVID response at CDC, and also share a few scientific updates that I think you'll want to be aware of if you aren't already. So obviously, this pandemic is remarkable. It's probably one of the most important, probably the most important health threat we faced, at least in my generation and in the last couple of generations. So far in the United States, as of today, there have been over 1.9 million confirmed or probable cases reported, and tragically, almost 110,000 deaths. It was just over 109,000, I believe, today. And I just want to take a moment for us to acknowledge the really tremendous toll this has taken and how it continues to affect all of us in every part of society. There is some good news. It's been about, we're at about 6 months, coming on about 6 months since this first emerged. And it's nice to see that we're beginning to see the impact of our efforts here in the United States to try and flatten that curve, due in very large part to social distancing and wearing cloth face coverings that all ordinary Americans from top to bottom are implementing. I'll just say that nationally, levels of COVID-19 as well as influenza-like illness continue to decline or remain stable or at low levels where if they haven't gone up before. Also, the percentage of laboratory tests that are coming back positive, that's also going down. And mortality attributed to COVID-19 is also going down. Although I'll note that that will take a little bit of time to get the absolute final numbers because it takes time for us to get the death certificates processed. I want to be clear, though, that although these are promising trends at the national level, we have definitely not flattened the curve everywhere and for everybody. Some communities right now are experiencing a pretty severe impact of the pandemic. And we continue to unfortunately see outbreaks in long-term care facilities, prisons, food processing plants, and other high-density congregate or high-risk settings. And as I hope you're aware, this pandemic, like many health problems in the United States, are disproportionately affecting persons of minority race and ethnicity, and in particular, Blacks, Latino Hispanics, and American Indians and Alaska Natives. We are committed to protecting these and other at-risk groups. It's been part of my work for 30 years, and have a remarkably dedicated team as well as leadership right at the top working to address these issues. I also want to emphasize that as jurisdictions ease up on their restrictions, some level of community mitigation will need to be maintained. We are not going to be able to go back to what we might have thought of as normal at the end of last year until either widespread effective treatment or a vaccine is available. And our success is going to depend on us having layers of protection. You all are aware that these things like social distancing, hand washing, environmental cleaning, cloth face coverings, each of these individually provides some protection, and they really do that the best when they're all used together. I do have a few comments, as I mentioned before, on the science side before I turn it over to my two great colleagues at NIOSH. Sarah mentioned that I've been involved in a number of infectious disease outbreaks in the past, and I'll just say that the scale and size of this event is unprecedented. You know, this came on like a tidal wave. I also want to remind everybody, this is not influenza. This is a new virus, and we are learning new things about it every day, and it continues to surprise. You think you know what's going to happen, and something else turns out. And that's why it's so important for all of us to stay up to speed with what's going on, and for each of us to assess our own risk for COVID-19 and act accordingly. You know, one of the most common questions I hear from when people come to me as a doctor is, how is COVID-19 spread, and can I get infected by doing this thing or that thing? And we do answer individual calls, but it's difficult to speak to every single situation. But a couple of things I want to say. We know that COVID is mainly spread person to person through exhaled respiratory particles. And these particles or droplets can be produced when a person coughs or sneezes, but also they're produced when people speak. And they infect us by landing in our mucous membranes, predominantly in our head, in our mouth, and our nose. And that's why that's one of the reasons why wearing fabric face coverings. God, it's going to take me a while to get that one down one day. Fabric face coverings or cloth face coverings. That's why they're important. We all know, I think, that masks were first developed to protect our lungs from inhaling infectious diseases, from inhaling dust and other particles that can damage them. But we now know with COVID that if I've got it, I could be shedding that virus, shedding at infectious doses before I have any symptoms that would let me know I might have it. So as a person who may have the infection and not know it, wearing a face covering also helps me protect other people in my community by blocking those particles in my exhaled breath. It is possible, we believe it is possible to get infected through other ways. This virus can live on surfaces, but getting infected by these so-called fomites would require that you not only touch a surface with the virus, there be an infectious enough dose present there, and that you then introduce it into your body somehow by touching your face or putting your finger in your mouth or your nose or in your eye. We also have learned that a variety of body fluids have detectable viral RNA, so there's a signal the virus is present, but we're not having an easy time culturing living virus from those fluids the same way we can readily culture this virus from respiratory specimens. So for instance, there's been many reports of high viral loads in stool, but there's been only one really good report that took a lot of work to isolate replication competent or live virus from stool, and many other attempts by some excellent laboratories where they have not been able to do it. So if it could be transmitted through stool and through other fluids like breast milk or semen, where there's also been detectable virus potentially reported, these are rare and may occur, but we really need to focus our attention on the respiratory droplets. I do want to remind everybody, in case you still have memories of Ebola where we worried about touching, that this is not an infection that can be transmitted by just touching somebody's skin or sweat. You'd have to touch skin or sweat that's contaminated with respiratory droplets. And I hope everyone recognizes that this isn't transmitted through food, and it definitely is not transmitted by insects like mosquitoes or ticks. You know, I personally, and I know many other people, are very interested in characterizing transmission, and we're working on that pretty steadily. I did want to just bring to your attention one really nice study that appeared in Lancet last week, a big epidemiologic study combining data about what we know prevents transmission from studies not only of COVID-19, which are pretty few, unfortunately, at the present time, but also pulling in data from what we know about SARS and MERS. So these are the three really bad human coronaviruses, the one that causes SARS, the one that causes MERS, and the one that causes COVID-19. And this is what they found that I thought was pretty remarkable. So distancing yourself 1 meter from an infected person, for a person who's 1 meter or more from that infected person, you are at an 89% reduced risk of acquiring COVID than if you were within 1 meter, okay? And every additional meter you put between yourself and that person doubles that benefit. Using a face covering of some kind. I almost said fabric face covering, but I should caution, there aren't enough data yet on those specific kind of face coverings to tell us how well they work compared to others. But in the studies that had masks of a variety of different types that included multi-layer fabric masks, 85% reduction in risk. And wearing eye protection, it could be in the form of glasses, it could be in the form of a face shield, that also conferred a very substantial reduction in risk of 78%. As I mentioned before, any of these can work well on their own, but you know what? They all work best together. I think that really is the bulk of what I wanted to talk about. Well, there's plenty of time for questions at the end, I hope. I appreciate your letting me rattle on for 8 or 9 minutes. And at this time, I'd like to turn it over to my colleague, Dwayne, to talk about Resuming Businesses Toolkit. Dwayne?
Thank you, Dr. Brooks. Yeah, my name is Dwayne Hammond. I'm part of the worker safety team at CDC. And today I am pleased to share information on CDC's Resuming Business Toolkit. The toolkit was first published on the CDC website on May 28th and can be found on CDC's coronavirus webpage. I'll ask one of our moderators to post a link in the chat. It's also on the bottom of our slide. The information in the toolkit is based on CDC's interim guidance for businesses and employers. We developed this toolkit because we know how difficult it can be for businesses to translate guidance into easy checklists for staff. We hope this makes the guidance as easy to implement as possible. So the Resuming Business Toolkit is designed to assist employers in slowing the spread of COVID-19 and lowering the impact in their workplace when reintegrating employees into non-healthcare business settings. The toolkit includes an employer sheet, a restart readiness checklist, a worker protection tool, and resources where you can find additional information. The first section of the toolkit starts out with an introduction called the employer sheet to introduce employers to the contents of the toolkit and how to use the materials in non-healthcare workplaces. The employer sheet encourages employers to consider how much the disease is spreading in the community and the readiness of workplace management to protect the safety and health of employees and the public before they resume non-healthcare business operations. The sheet points employers to CDC's decision tool that can help determine if it's time to resume operations and recommends checking conditions in their community by contacting a local health department. The next section in the toolkit is the Restart Readiness Checklist. which is designed to help make return to work and resuming business operations as safe and healthy as possible for employers, employees, and the public. The Restart Readiness Checklist includes more than 80 items with boxes to check whether Restart Readiness Checklist items have been completed, whether they are ongoing, whether they have not yet been started, or whether they are not applicable. Employers should only complete those items that apply to their business. The items on the checklist fall under three main categories of preventing and reducing transmission among employees, maintaining healthy business operations, and maintaining a healthy work environment. Examples of subcategories under the main category of preventing and reducing transmission among employees include conducting a hazard assessment of the workplace and determining whether you have a plan for what to do if an employee is sick at work. It is important to note that many of the subcategories and checklist items link to other CDC guidance, such as the CDC web pages on what to do if you're sick and CDC's Symptoms of Coronavirus webpage, which allows the checklist user to do a deeper dive of certain topics if they need more information. The second main category, checklist category on maintaining healthy business operations includes subcategories such as establishing a COVID-19 coordinator, implementing sick leave policies, protecting higher risk employees, communicating supportive workplace policies, evaluating essential functions, having a plan for employee absenteeism spikes, and establishing social distancing policies and practices in the workplace. The final main category in the checklist is about maintaining a healthy work environment and includes subcategories on modifying your ventilation systems, ensuring the safety of the water systems of your building after a prolonged shutdown, supplying employees, customers, and visitors with what they need to clean their hands and cover coughs and sneezes, performing routine cleaning and disinfecting, limiting travel, and planning meetings and gatherings to lower risk. In addition to the main checklist, our business toolkit also has a worker protection tool for employers to identify protective measures for workers when interacting with each other and the public. The tool allows the employer to consider the exposure that workers will have to potential sources of COVID-19 when they resume business operations. Employers can use this tool to identify protective measures for interactions between workers and or the public, and they can revisit the tool on an ongoing basis while COVID-19 cases exist. Employers are encouraged to only complete items that apply to their business. The worker protection tool follows the hierarchy of controls and includes engineering, administrative, and personal protective equipment considerations. The engineering considerations include 8 facility and equipment items, such as ventilation and water systems, and altering the workplace to maintain social distancing. The administrative control section includes 26 items that fall under 3 categories of management and communication, cleaning and disinfection, and training. The final section of the worker protection tool includes several items to consider for personal protective equipment, such as determining the needed PPE for workers' job duties based on hazards and existing protections. At the end of the worker protection tool is a returning to work infographic to remind employees how to protect themselves and others from COVID-19 and address their potential concerns about returning to the workplace. Finally, there are multiple resources at the end of the toolkit to easily get additional information using hyperlinks, URLs, and QR codes. We know it may be hard to keep track of the many guidance documents that may be relevant to your business. So to make that easy, we've added many links, footnotes, and QR codes all in one place. With that, I'd like to thank you for your attention and turn it over to my colleague, Dr. Matetic, to talk about more specific considerations for manufacturing settings.
Well, thank you, Captain Hammond. Good morning, good afternoon, and probably morning to some of you. I am Dr. R.J. Matetic. I'm the Associate Director for Manufacturing and the Manager of the Manufacturing Sector Program for the National Institute for Occupational Safety and Health, or NIOSH, which is part of CDC. Today, I am going to speak briefly about the interim CDC and OSHA guidance for manufacturing employers and workers. As we all are aware, manufacturing facilities are an integral part of the U.S. supply chain. However, the manufacturing work environment, such as production or assembly lines, and other areas in busy plants where workers have close contact with coworkers and supervisors, may contribute substantially to workers' potential exposures for COVID-19. CDC and OSHA have developed this new guidance to help manufacturers decrease the spread of COVID-19 and lower the impact of the virus on the workplace. It applies to many different types of manufacturing, including food, textile, apparel and footwear, chemical, plastic, metal and wood product manufacturing, and among others. This guidance outlines prevention practices that can address these challenges and help reduce the risk of transmission and illness from COVID-19 in manufacturing facilities. In manufacturing, the risk of transmitting the virus is related to several factors. First, we need to recognize that it's not always possible to keep 6 feet of physical distance between workers. They often work close to one another on production or assembly lines. Workers may also be near one another at other times, such as when clocking in or out, during breaks, or in locker or changing rooms. Additionally, manufacturing workers often work near their coworkers for long periods of time, generally for 8 to 12 hours per shift. This kind of prolonged contact increases the risk of transmission. Manufacturing workers may be exposed to the virus through respiratory droplets in the air. For example, when workers in a plant who have the virus cough or sneeze. It is also possible that exposure could occur from contact with contaminated surfaces or objects, such as tools, workstations, or break room tables. Shared spaces, such as break rooms, locker rooms, and entrances and exits to the facility may contribute to their risk. There are a couple of other distinctive factors that may increase risk among these workers. First, it's common at some workplaces to share transportation, such as rideshare vans or shuttle vehicles, carpools, and public transportation. And second, frequent contact with fellow workers in community settings and in areas where there is ongoing community transmission. In other words, coworkers may spend time together outside of work as well. A very important step for an employer to take is to assess your workplace for COVID-19 risks and develop a health and safety plan. As part of these assessments, facilities should collaborate with local and state public health officials and occupational safety and health professionals to consider the appropriate role for testing and workplace contact tracing. In other words, identifying person-to-person spread. The new manufacturing guidance has recommendations for infection prevention that employers can incorporate into their health and safety plan. As part of these assessments, facilities should collaborate with local and public health officials and occupational safety and health professionals to consider the appropriate role for testing. These recommendations, as I mentioned earlier, are based on an approach known as the hierarchy of controls. This approach groups actions by their effectiveness in reducing or removing hazards, so you start with the most effective interventions, and if those aren't possible, you go down the list to the next most effective set of interventions and so on. In most cases, the preferred approach is to 1, eliminate a hazard or process, 2, install engineering controls. This might mean reconfiguring the workplace so that workers can be 6 feet apart or installing physical barriers between workers. 3, implement appropriate cleaning, sanitization, and disinfection practices to reduce exposure or shield workers. 4, administrative controls, which are changes to the way people work, are also an important part of an approach to prevention in these workplaces. An example of an administrative control is to stagger start and end times to prevent workers from congregating around time clock. Specifically, facilities can address these hazards using a range of approaches, including the following. Facilities should implement controls to separate workers as much as possible and encourage social distancing. For example, by installing barriers, adjusting employee workstations, and staggering arrival and departure time. I can also speak on more examples in the Q&A session if you'd like. Employers should provide hand washing stations or touch-free hand sanitizers with at least 60% alcohol in multiple locations to promote hand hygiene. Employers should encourage sick workers, including those who test positive but remain asymptomatic, to stay home. This might require modifying leave policies and ensuring that employees are not penalized for taking leave if they have COVID-19. Employers should provide basic infection prevention information and training, including training on social distancing and ways to reduce the spread of infection for all workers in their preferred language and at a literacy level they understand. Employers should increase frequency of cleaning and disinfection of shared equipment and shared spaces. Workers who perform cleaning and disinfection tasks may require additional PPE and other controls to protect them from chemical hazards posed by disinfectant. In addition, screening workers for COVID-19 symptoms, such as temperature checks before entry into a facility, is an optional strategy. Policies and procedures for screening workers should be developed in consultation with occupational medicine professionals. Workers who appear to have COVID-19 symptoms upon arrival at work or who become sick during the day should immediately be separated from others at the workplace and sent home. Workers with COVID-19 should not return to work until they have met the criteria to discontinue home isolation, which are covered in detail in the CDC guidance titled Discontinuation of Isolation for Persons with COVID-19 Not in Healthcare Setting. Cloth face coverings are recommended by CDC in public settings to potentially help prevent people who do not know they have the virus from spreading it to others. Face coverings are generally recommended as an addition to social distancing, and they may be especially important when social distancing is not feasible based on working conditions. Cloth face coverings are not appropriate substitutes for persons in jobs that require or recommend the use of respirators or medical face masks. If cloth face coverings are worn in these facilities, employers should provide readily available clean cloth face coverings or disposable face mask options for workers to use when the coverings become wet, soiled, or otherwise visibly contaminated. And lastly, workers should continue to wear personal protective equipment required for the job task being performed. Management should ensure that PPE is correctly used by all workers. Face shields can serve as personal protective equipment for job-related splashes and as a way to prevent infected individuals from spreading infectious respiratory droplets.
Excellent. Thank you, gentlemen. So we'll go ahead and dive into some questions now. We received a number of questions this last week, in particular a number tailored towards businesses, but also a few that are relevant to a broader audience. In particular, there were a number of questions about testing. So I'm thinking we'll start with those questions just since they may be of interest to everyone on the line, since I know our audience is quite diverse. So I'll start with John. John, if you, just thinking about testing and new tests on the market, can you compare some of the technologies and which ones are seen as most effective? For example, antibody versus viral tests, rapid tests, at-home tests?
Excuse me. Yeah, sorry about that. I was just trying to get off of mute. I'd be happy to address that. And it really is kind of remarkable. First, just the number of tests that have been developed in less than 6 months. I mean, if I'm not mistaken, I believe there are now over 60, maybe 70 antibody tests, and tens of these PCR tests, and now there's an antigen test, and home test kits are being developed. So it's pretty amazing how quickly American business and the scientific community and academic community have responded in helping us here. But what that also means is that there's potentially issues around quality control, and we can talk about that a little bit later. But just first, let me make clear what some of the different tests are and how they're intended to be used. So when a person becomes infected with this virus, like with any other virus or bacteria, and it takes hold in your body, that pathogen begins to replicate. The virus is using your cells to make copies of itself. And in the course of doing that, more and more virus grows. Some of that virus is RNA, the genetic material that contains the program for actually creating the virus, spills out into respiratory secretions. And that's what the PCR test is sampling. The PCR test is designed to tell me if the person who was previously well might have a new infection. And as the virus begins to replicate in the person's body, the amount of RNA I can detect, the quantity of RNA goes up. And so that PCR test is a good test for when the person, to demonstrate the person has recently been infected. Now, as we recover from an infection, very shortly with this infection, when we recover from an infection, our immune system kicks in. So within a few days in many people, after they've begun to feel sick from this virus, their body begins to produce antibodies. We don't know for sure if those antibodies will protect that person against a reinfection, but they seem to work at helping bring down the infection they have right now. We've seen that as the antibody levels are going up, the ability to recover live virus that can infect cells in a cell culture, let's say in a laboratory, starts to go down. And the amount of virus that are in the samples we're getting is also going down. So that suggests that the immune system, both antibodies and what we call the cellular immune system, there's the humoral or antibody system and the cellular system, these work together to get rid of that virus in your body. So one of the phenomenon we're seeing that I wanted to bring to people's attention is this phenomenon where people continue to be tested with the PCR test even after they've fully recovered. And some people keep having a positive PCR test. And there are good data now that show that that can go on for as long as 6 weeks. In fact, in the most extreme example I've seen published so far, it was 83 days. This can lead to some pretty unfortunate circumstances where people are kept in isolation or kept away from work or kept away from their loved ones or not brought back to the home or their long-term care facility because their test is persistently positive. We now know that in particular from a really beautiful piece of work that was finished in South Korea a few weeks ago, that people who are fully recovered and have these persistently positive specimens don't pose a risk of infection to others. In this study in Korea, they had hundreds of people like this. They followed all of their contacts for 14 days after that re-positive is what they were calling it, was detected, and none of those contacts became infected from exposure to these cases. And in a subset of those cases, 108 people, where they tried to culture the virus using well-validated international methods for viral culture, they couldn't culture the virus. So we know that at some point you're just shedding blanks, okay? The problem is, where is that place? And we're working now, we and many other groups around the world are working now to trying to find where that is so that we can help people sort of get out of jail, if you will, because the test that was designed to diagnose infection in some people, because they persistently shed virus particles that are not infectious, even after they've recovered, is keeping them back from rejoining the rest of society that we're trying to open right now. We'd like to be able to use an antibody test to say that the person is fully recovered. And I mentioned that many people do develop antibodies, and we're working to see how that might inform if the person's recovered from their infection, but we're just not there yet. Other tests that we're looking to use are antigen tests. So the PCR test detects a kind of protein called an RNA. Technically, that's a form of antigen, but that's specifically RNA. There are other proteins and so-called glycoproteins that the virus makes and that get into your specimens that we can detect, and they will start to go up before the antibodies go up. And we're learning, there are just a couple of those right now. They've been very useful for diagnoses in other diseases like HIV and syphilis, and we're working on how they may help us here make sure that a person has a truly positive infection and it isn't a false positive infection. And then lastly, I'm really excited by some of these home test kits that are coming along, because what these can do, those could really help us in one important way. For people who've been exposed to this virus, we recommend that they quarantine themselves at home or away from other people for 14 days. And that's because after an exposure to the virus, if you're going to become infected from that exposure, it can take up to 14 days for that to happen. That's the extreme. 99.5% of people will have declared their infection, will have developed an infection by that 14th day, and the median is right around 5 days. But to be safe, we really want people to stay quarantined for 14 days. And it's possible that during quarantine, a person can become ill. Well, we use quarantine for that purpose, so that they're away from other people and monitoring themselves to make sure they don't get sick, so that if they get sick, they can be brought to medical attention rapidly and removed from possibly infecting other people. If you have a home test, you could test yourself every couple of days, or if you have symptoms, to see if you might have an infection, and then you would know that you need to stop quarantining and actually get medical attention and become isolated. So that could be a really powerful tool. It could also be really helpful just for people to be able to test themselves when they want to and at their own leisure. So I think I'll stop there and see if there are any other questions. Sorry for the long answer.
No, that was fabulous. Thank you so much. And we do actually have a couple questions that have come in around testing, but I'm gonna jump around a little bit and switch some gears to business and manufacturing. And so thinking about specifically the guidance that RJ and Dwayne had spoken of earlier, businesses and manufacturing type guidance, I'll ask RJ, can you recommend some specific strategies that manufacturing lines and other crowded business settings could use when thinking about spacing out their workers?
Yes, thank you, Sarah, for that question. And as I mentioned previously, we all should understand the hierarchy of controls and try to utilize them as best as possible. So given that view, facilities should implement controls to separate workers as much as possible. And I know that's not always easy to do. Some things employers can do is install barriers or adjust workstations so workers can stay at least 6 feet away from other workers. Additional things that could be included is adding additional clock in and clock out stations and rearranging break areas. It can also help reduce crowding in those areas. Social distancing is very important. Employers are encouraged to promote social distancing, and they can do that through different ways. Some potential options include staggering breaks and arrival and departure times at the facility, limiting facility access to essential workers only, eliminating non-essential meetings, or breaking larger meetings into smaller group meetings where spacing is possible. And finally, encouraging workers to avoid sharing transportation if that is all possible as well.
Excellent, thank you. Also, I guess I'll also pose this to you, RJ, while I have you. CDC recommends that businesses, including manufacturing plants, designate a COVID-19 workplace coordinator. Can you speak a little bit more about what that person's role is?
Yes, and again, Sarah, thank you for the question. In my earlier presentation, I mentioned to all of you about the COVID-19 health and safety plan and the recommendation of a workplace coordinator. A qualified workplace coordinator should be identified who will be responsible for COVID-19 assessment and control planning at your individual facility. All workers in the facility should know how to contact the identified coordinator with any concerns any of those might have. The workplace coordinators and management should also be aware of and follow all applicable federal regulations and public health agency guidelines. And lastly, CDC's resuming business toolkit, as Captain Hammond mentioned, is a great place to start, as well as the more specific guidance we have for many industries, including manufacturing and many other settings.
Excellent, thank you. We received a number of questions last week in regards to traveling, especially for business travelers. So one thing to consider is whether it's local travel, regional travel, or internationally, what should people do to determine the risk of travel? And if they want to travel safely, even if it's not essential travel, can they do that? And I think I'll start with Dwayne for that one, and then maybe switch over to John if he has any thoughts.
Thank you. Yes, CDC still recommends postponing non-essential travel at this time. However, as the country continues to reopen, decisions on when and where to travel should be based upon a risk assessment of the affected communities. Our business toolkit includes several checklist items related to travel. Businesses should limit travel and advise any employees who must travel to take additional precautions, such as minimizing non-essential travel, check CDC's traveler health notices, including for health information unrelated to COVID-19. Advise employees to check for symptoms of COVID-19 before travel. Sick employees should not travel. Ensure employees who become sick while traveling know what to do, including calling a healthcare provider for advice if needed, notifying their supervisor, following company policy for obtaining medical care when abroad. And I'll turn to my colleague, Dr. Brooks, to see if there's more he'd like to add.
Yeah, that's great advice. And I just want to say that a couple of additional things, just very practical things. You know, if you don't have to travel, don't travel, obviously. But some people, we can't help it. You have to. And I just want to reassure folks about a couple of things. First of all, when you're in an airplane, don't feel empowered to, because it's your health and their health that matters, feel empowered to tell people to please stay apart, that you're doing this to help all of us, that thank you for wearing a mask. Sometimes on some airlines, they're being very helpful and accommodating in creating spaces between patients by, travelers. Hopefully they're never patients, between travelers by blocking off seats. But if you can't do that, respect the other person. The most important thing you can do on the plane to stay safe is to use hand sanitizer on the plane or wash your hands frequently. It's perfectly fine to sanitize the area around you. I would appreciate it. The next traveler would appreciate it. I'm sure the airline would appreciate it. But just know that viruses don't jump off of surfaces into your nose and into your mouth. If you keep your hands clean, then anything you touch is removed and cleaned and won't get into you. And when I travel, I keep a bottle of the hand sanitizer with me at all times, and every time I take it out every 20-30 minutes and use it just before I drink the soda, before I open. Well, I guess I know nowadays I don't even give you snacks anymore, but before I read the escape card, the passenger safety card or anything like that, just so I feel reassured. And of course, wash my hands when I'm in the bathroom. And if you have enough, offer it to your seatmates if they're adjacent.
Excellent, thank you so much. I'll pose another question to Dwayne, just about how businesses should write their COVID policies if they have work sites in multiple states or jurisdictions. In that case, what guidance should they specifically be following?
Well, local authorities having jurisdiction will have the final say on minimum levels of protection and protective activity. Workplace protection policies that are more stringent than the local requirements should continue to be followed.
Excellent, thank you. I'm going to switch back over to John, Dr. Brooks, thinking about another general question, though we get it quite frequently, is kind of what's the latest information on immunity and reinfection. If someone recovers from COVID-19, do they need to worry about being re-exposed again?
Yeah, that's boy, that's a great question. First, I'll just say, I don't know. I wish I had a firm answer. A couple of things we do know. We do know that people, when they've been infected, are developing a immune response that appears to be effective in a petri dish. And when I say that, what I mean is that when you take that person's antibodies and you try to use their antibodies to protect cells and culture from being infected from the virus, they neutralize that virus. They prevent the virus from infecting those cells. That's great news. But we know that that test does not always correlate with actually the presence of true infection against reinfection. It's a good sign. The fact we develop antibodies, the fact that some of them are neutralizing, as I've described, that's very helpful. Secondly, there have been some animal experiments where they have taken our cousins, macaque primates or monkeys, and infected them with the virus, and then when they've tried to reinfect them after they've developed an immune response 30 days later, and they try to reinfect them with the same strain of virus, they've not succeeded. These are small trials. I mean, it's in the orders of like ones to tens of animals, but it's reassuring that things are looking good. The other thing is that we have not seen a report yet of a person who has been reinfected. There are these people who that have been mistakenly called reinfected because they had those positive PCR tests after they recovered, and people's first thought was, dang it, they've gotten infected again. Well, we now know those are probably people who just are taking a long time to completely rid the virus particles from their body. But we haven't seen a really ironclad case of reinfection. I'll just say, though, that those may be hard to recognize. It might be possible that a person gets reinfected, and the second infection is so mild they don't notice it and would never be brought to medical attention, but while infected, they could infect other people. So we can't say it's not possible. It's an area of really intense work right now. But until we know for sure what it means, we have to assume that there is some possibility. And I'll just note that with the common cold viruses that are due to forms of coronavirus, people can get reinfected from those, although it's not immediately. It's usually a year or two later. So hoping that we have an answer definitively in the near future.
Excellent, thank you. I know I want to recognize the time. I know typically we wrap up these calls about 45 minutes after the hour, but we did get a lot of questions in the chat box, so I'm just going to ask two more questions of folks. RJ, a lot of folks have questions about face shields, specifically thinking about face shields within a manufacturing setting to protect workers. Can you explain how they should be used and if they should be used in combination with other materials?
Sure, Sarah. I can shed some light on that. As we're aware, face shields may serve as both PPE as well as source control in manufacturing settings. However, I do need to note that a face shield does not replace the need for a filtering respirator such as an N95 in scenarios where respiratory protection is required. Face shields can also provide additional protection from both potential process-related splashes and potential droplet spread to others. A benefit of using a face shield is safety glasses may fog up when used in combination with masks or cloth face covering. However, we need to understand only some face shields are acceptable substitutions for eye protection, such as safety glasses that are used for impact protection. Facilities should consult with an occupational safety and health professional concerning the use of face shields. I need to mention as well that if helmets are being used, use face shields designed to attach the helmet. Also, face shields can help minimize contamination of masks and cloth face covering. If used, face shields should be cleaned and decontaminated after each shift. And when not in use, they should be kept in a clean location at the work facility. If face shields are used, they should also wrap around the sides of the wearer's face and extend to below the chin. And finally, like my last comment on face shields is, in addition to using face shields, workers in manufacturing facilities may still need other types of PPE. For example, when cleaning and disinfecting manufacturing plants, tools, and equipment.
Excellent, thank you. And I think I'm going to make this last question for Dr. Brooks, for John, just thinking about you being our Chief Medical Officer for this response. I know a lot of folks are still feeling anxious about the idea of going to the doctors these days, even though we're still getting sick, you know, even the common cold, other reasons why we might want to see a doctor, or I know the dentist is a real need for a lot of folks. I wonder if you've got any advice for people who are concerned about going to healthcare facilities during this time of COVID-19.
Yeah, I have thank you for asking that, Sarah. That's so important. I think many of us early on, the message was stay at home, stay at home, stay at home, right? But we know that some people have, we need, let me put it to you this way. We need to now all know that the healthcare system is safe and is ready to receive and take care of us and protect us from getting COVID. There's now been a lot of experience, and places have learned how to manage that risk in a way that if you're infected with COVID, that you won't give it to the healthcare workers or other folks, and if you don't have COVID, that you're protected it from getting it from other people. The unfortunate thing is that we've seen evidence that people are delaying care, and it's caused death. In both Europe and this country, there have been real drop-offs in the number of people seeking emergency care for things like heart attacks or bleeding or strokes. And at the same time, the number of people found dead at home from heart attacks and strokes is going up. And when speaking to the next of kin, you know, some people delayed care because they were more afraid of getting COVID, but they should have been afraid of maybe dying from something that was preventable. So please go to the doctor if you have any reason. They're ready to help you. You may want to call ahead. You can call 911, but don't delay. And this is also true for people getting ongoing care. If you're receiving care for cancer right now, or you're receiving any other form of immunotherapy that requires you to go to the hospital, or you need dialysis, don't delay. We're ready to help manage that now to keep you safe. If you can delay the cleaning of your teeth a month or two, okay, that's fine. But eventually we've got advice, and we've got ways to make it safe for folks to receive the care that's important. I just want to remind folks that our success in managing this pandemic is not just going to be measured by the number of COVID infections we prevent and the number of deaths that we prevent from COVID, but also by the number of illnesses and deaths from all the other conditions that are out there that are occurring. You know, it's incumbent on us to not only make sure we prevent COVID, but also don't, if you will, rob Peter to pay Paul and let people die of other preventable things.
Excellent. Thank you so much. I really appreciate that. And I think it was a lovely way to wrap up our call today. So thank you, everyone, for your time. And I want to thank the speakers. I think it was a great dialogue. We're very hopeful that those who called in today will join us next week. As I mentioned in opening up the call, we're still debating on the time slot. We're finding benefits for 3 o'clock as well as benefits to keeping the call at 4. And so you can expect to receive details associated with next week's call during the coming days, and get more information about what we decide in regards to the time at that time. But again, thank you so much for your time, and we hope that you'll join us next week. Good luck with your week, and have a good day. Bye-bye.